Hello, people.
Hey Adam, how are you doing?
Hey.
Like we just talked to each other yesterday.
You have a very professional background there.
Oh, well, I built that for some like platform talk I had to do at a conference. And then I've never done anything different, got anything more creative or amusing or lesser so. And I was using it, we were doing all of our like resident and fellow interviews via Zoom as well. So it seemed an appropriate setup for that. I have a couple of colleagues here who have far more amusing things that I need to sort of invest myself into at some point.
Yeah, I had to tell people like there's definitely an art and a science to the whole Zoom interview. You know, like you have to have the front lighting.
Yeah.
You can't have the window open behind you.
Yeah, my like little office space, we moved in a new house back in August and it's just like a blank white wall. So it does nicely for like backdrop for what I want to do. So that actually ends up working out really well.
You can green screen in the ideal office setting. Don't they have that app on Twitter or the commentary on Twitter, the Room Rater?
Oh, I've heard of that. I don't have a Twitter. I have very little in the way of like social media. I'm very like not involved in that. So I've heard of it.
So you've heard about GameStop then?
The term is familiar, but that's pretty much it.
So that's the big, I mean, it's in the regular media now too, but a bunch of people on Reddit figured out that people were trying to short the stock. So there was just a group of people on, the Reddit social media that decided to buy it. So now it's gone up like 1,000%, and there's newly minted millionaires out there that are basically doing like an option squeeze.
Always some sort of scheme.
Keeping life interesting.
I wish I would have been able to invest on that.
Yeah, there was somebody on one of the physician dads groups was showing his ledger, which is fairly impressive, but I don't know. You figure like there's only really a couple of people that made out well. Everybody else who tries to get in on it is going to get hosed eventually.
I was gonna say, Henry, you still can.
Yeah, or well, no, they're locking it down actually, because actually one of my friends is actually loves that, playing that game of investing, and he was trying to get into the AMC scheme, but there are already some restrictions already.
Oh boy.
Plus, I think the last thing I heard, the GameStop was already down, I think 20% from what it was. So you never know when it's going to drop like -200 probably to compensate. So.
Right. I mean, it was like a $1 or a $2 stock at the beginning of all this. And that's probably like market-wise where it should be, if not lower. And then it's been at what, like 300? It was 300, 400 at close.
I don't remember. Yeah, because I was post overnight, so I couldn't follow the way through.
You were thinking of other clinical things.
Adam, in all your travels with API research, have you ever come across I haven't actually found the study itself, but I was talking to a radiologist who was talking about incidental appendicoliths that are found on either ultrasound or CT. And, with lack of right lower quadrant pain, how the incidence of like actual appendicitis is like negligible. And I don't know if you would ever, thought about.
Yeah, I've bumped into a couple of like random appendicolists in kids, and even some like decent sized ones where it's like, wow, like maybe you will have appendicitis in a week or so. And of course they didn't.
Yeah, that's how it came up. I was trying to teach someone how to look for appendicitis, and this kid had like a 5 millimeter appendix with a rock right in the center, and I was like, "What do I do with this?" But
Yeah,
I never come across that one before.
And Adam, did yours have like because I had a couple, and one of them had like normal inflammatory markers. We always get CRPs that are in my shop, so it was normal. The other one was high, so I kept checking. I was like, he's gonna come back, perf, but he never came back. So I was like so confused by this. So
I even had a kid very early on that might have been back in fellowship if I remember, where right where it took off from the cecum, like that's where the appendiculate was, like very proximal. And this must have been in fellowship because he was admitted, because back in the day, radiology went home at like 5 o'clock, and so he admitted the kids for their 8 a.m. ultrasound. And when I followed up on the kid, like their ultrasound was totally normal, like nothing there. I can only imagine like this appendiculate was like at the opening, and then just it had to have fallen out. Like where else could have happened to it? But yeah, it happens. You bump into them.
Yeah, that was like my kid. It was super proximal. That's interesting.
But of course, like it's totally unstudied because
we're the only people.
that was the most proximal thing I'd seen, and coming on 13 years later, haven't seen another one like it.
Yeah. Yep.
It's time, Adam. So it's time to like. Thanks everyone for joining. But then today is going to be Dr. Adam Sivitz going to be talking to us, presenting some clinical cases. Hope you guys enjoy, and then I'll be sending out emails about next week's presenter with needs assessments. That'll be coming up, and then we're booked through April, so no one has to worry. So you'll just get emails from me after that. So otherwise, thanks everyone for collaborating and jumping in on to present. But without further ado, here's Adam.
All right, let me take over the screen. All righty. Sorry, I just need to minimize this. Silly Zoom. All right, guess that won't go away. All right, well, thanks everybody for joining on. I have a bunch of cases here. Feel free to, interrupt or shout kind of whenever. All of these things are much more interesting when people join in. So you can unmute yourselves as long as you're like not doing the dishes or chomping on some lunch. So we're gonna have a little theme for these cases. Case number 1, 5-year-old. Had a PICU admit very early on in life for a diarrheal illness. And since then had been followed by GI for some intermittent constipation. They presented to an outside hospital actually with like profuse diarrhea. The person doing the transfer was like, they're pooping out every couple of minutes. And they were really, really worried about the kid. And I think even like the sepsis alert in their EMR went off. So they were very distressed about this kiddo. There was no history of fever. There was no vomiting. And other than some like crampy abdominal pain, the abdominal exam wasn't that bad over there. So the kid finally got to us. We had some labs already cooked, and you can see them there. Nothing too exciting about any of these things. And, with the kid in front of us, the belly was a little bit tender, very non-specific. So in most of these kids, especially these days, with volume being as it is, we're just going to drop the probe on and see what we're going to see. So I think this first clip is coming from around the right upper quadrant, coming down to the right lower. So there was a tip of the liver in view. And hopefully the video is not too jerky. I never know what I'm going to get with the bandwidth at the hospital here. But hopefully we can appreciate this is, you know, pretty much normal looking bowel coming from that edge of the liver down to, you can see the bladder peeking in on the right-hand side there. Most of this is colon. You can see some haustra. You're really not seeing any peristalsis of the small bowel here. So really kind of like a nothing burger on that right side, which is, you know, the side I like to look at for some fun. Eventually we moved over to the left. And this is what we bump into. So that's the bladder that's coming in from the left side. The psoas muscle is kind of down in your bottom right. It's a transverse view. This next one is in sag. We're going to do a little sweep. Oh, sorry, maybe this one's still in transverse. Yes, it's still a transverse view. So there's a bladder again. So we're seeing this loop of bowel, left-sided. You can see it's draping over the vessel over there. Comes kind of across and behind the bladder. So what are we probably looking at here? Any thoughts, any differentials for this otherwise healthy 5-year-old kiddo?
Was it a male or a female, Adam?
Female.
I forgot. What was it?
Female, just diarrhea. Watery, a little smelly.
I wrote it in the chat, but from what I see on these images, it's a little grainy. I don't know if it's my internet, but there seems to be sort of peri-intestinal fluid, like there's a dark rim around all these intestines, and there's a lot of content within, so I can't tell exactly about to and fro or not. And then thickened bowel wall for sure. So at the minimum, enteritis plus minus after a diameter, like is there SBO or something?
So
sorry, it can't be SBO. He's got diarrhea, so sorry.
It could be a partial SBO still. I mean, you know, that was one thing with the when that to and fro stuff came up in the EM literature. And this would probably be like a nice little project for a couple of places that do a lot of bowel imaging. But I feel like I see to and fro and, you know, some dilated loops a lot with pediatric gastro. And, you know, it's kind of been a joke now that we're seeing a lot more of like these older kids in our peds ED because of the volume and whatnot. But like today, you know, I was looking at some 21-year-old that was on the main side instead of peds, and they were doing like this whole big workup for, you know, diarrhea. And I'm thinking like, man, if this was a toddler, you'd like throw some Zofran at him, watch him, you know, take a sip or have some crackers and send him back out. So yeah, we probably send home a lot of partial SBOs and ileus associated with GI illness, and you know, they're able to hold on to their hydration status and it passes. But in this case, there wasn't any. And you know, actually this loop of bowel isn't small bowel where we would really see that good to and fro stuff. I mean, from the positioning here, especially since we're seeing it go behind the bladder, this is really like sigmoid to descending colon that we're looking at. And, you know, kind of, as you mentioned, Rosemary, there's pretty diffuse bowel wall thickening here. You can see some air within the lumen. You know, there's some grayness around there, so like some inflammatory change around these loops, but very isolated to these loops, right? Like when we were looking on the right side, and you'll just have to take my word that that was the same in the middle and the transverse, it was nothing, like totally normal looking stuff until we got to this, you know, really focal isolated section of bowel. And I will say that the diarrhea was of larger volume and watery, and was not bloody at the initial time of presentation. So, you know, this was a kid that just, yeah, you know, they had a lot of diarrhea. They still had a lot of diarrhea with us. She really wasn't into eating, and you couldn't force a 5-year-old to do it. So got admitted for what I thought was just going to be a short OBS admission. She actually ended up staying a couple of days, long enough for me to come back at another time during her admission and re-ultrasound her up on the floor. And, you know, I had told the admitting team, you know, what I saw in the POCUS, and she was being followed by GI for something else, but GI came by and, you know, said hi to her, told her what was going on. By the 4th or 5th day of admission, she actually developed some bloody diarrhea, or sorry, 3 days there. And then from here, you can see there's additionally some more free fluid that you can see on like the top left-hand side of the machine. The ultrasound unit they have up in the PICU doesn't really have a curvilinear probe, it just has a cardiac. So that's what I'm scanning with here. But because of the bloody stool, this history of diarrhea, they did send a calprotectin on this 5-year-old kid, and it ended back at 1260 now. I couldn't remember the last time I had sent a calprotectin on a kid, because I don't think I'd ever sent a calprotectin on a kid, but this is what they use for monitoring for IBD, and normal levels are like under 25, under 50. And so this is somebody that you guys are going to follow a bit closer because of this elevated level. So, you know, it's kind of an interesting case. I would have never have thought IBD or even like a new presentation of it in a 5-year-old kid. So I kind of went back to the files and pulled the cases of, there's a couple of cases of IBDs and Crohn's that I had, and wanted to get a look at what, you know, those isolated bowel segments looked like. So this is, these are all teenagers of one age or another, but this was a known Crohn's patient who was coming in with a Crohn's flare, and this is like TI. So you can see psoas in the vessels on the left-hand side, and then you have this really kind of like focal segment where, you know, bowel wall edema surrounding inflammatory change. And it was very much isolated to, again, just this one segment. This was a kid, and I apologize because when whoever the fellow was doing the scan, they had the vascular left on the entire time. But if you look at the top right corner, so this person actually did have some to and fro and some dilated small bowel loops. And then coming from that top right corner, again, that would probably be the descending colon coming down our view. You know, a very isolated, very thickened bowel wall. And this was another kiddo. Had some very dilated loops again. You get a little bit more of your to and fro, but then there's that isolated segment. Again, this is probably TI and cecum, where you get that really inflamed bowel, different from, you know, bowel in other areas. And I think this is probably the last example. Oh yes, this is a little bit of a different flavor. So again, this was another new IBD kid. And this one people may have, I don't know, do people think this one's anything different than the last couple that I'd shown? And I say that to invite the response. So it may be hard to appreciate. And again, I don't know how jerky this is coming out on your guys' screens, but you have that isolated loop of bowel coming here, and then you have this other section in this area where you just have fluid, and you can kind of see it like intercalating here. So this was a kid that was a new onset Crohn's who also had an intra-abdominal abscess. The interesting with him is he was treated medically for a couple of days and then became lost to follow-up and ended up representing like 3 months later with a fistula formation from this thing. So a little bit unfortunate for him. So, again, the kind of the moral with this case is we do a lot of bowel imaging because of what we do and looking for appies or looking for intussusception. And, we should be getting used to seeing what normal stomach looks like, what normal small bowel looks like, what normal colon looks like, what SBOs look like, and kind of what gastro does to the mucosa and surrounding structures. But this was a case where, the bowel looked very different, and in its difference, looks a lot like what IBD or how IBD presents. And I have yet to find like a salmonella or a Shigella case where you would also have like a colitis that gives you this kind of appearance. So, for me, and my mental processing when I see that really, distinctly thickened bowel wall, I'll probably start ordering some calprotectins, which I haven't been doing before.
Adam, did you get like a C-reactor protein or ESR in that kid by any chance?
Yes, the CRP was mildly elevated. The ESR was like 10.
Are you able to point out exactly where the abscess is? Are you seeing it well on this clip?
So I'll stop it where, yoink. So right here, you have this grayness, this blackness, this is fluid. You can see it intercalating over here, and then you'll see it kind of go over that way. But intra-abdominal abscesses kind of behave the way that those, the staph phlegmons do. You can get a nice walled off abscess, and it looks like a ball. But a lot of times, with these ruptured appy abscesses or the IBDs, you're just going to get this like kind of messy looking fluid that's in between the bowel loops. And there really shouldn't be anything else between bowel loops. You can have the fat stranding where things just start getting gray, and you can get some simple free fluid, which is like a nothing burger. But once that fluid starts looking gray, then that has to get you thinking about intra-abdominal collection.
Great, thanks.
All right, next case. All right, 16-month-old, belly pain for a day. Also history of constipation. Everybody's constipated in New York. No vomiting, no fevers, no blood in the stools. And let's see what we see here. All right, so we're all the way on the right-hand side. There's that edge of the liver again. Coming down, we have a little bit of the colon. We're seeing some small bowel coming on the right-hand side. Fidgety kid. I think he was one of those that like you put the probe on his belly and he looks over the screen and he starts like moving the belly up and down, trying to get the probe to move with him. Here's a little bit more transverse. There's the bladder on the left-hand side. And we're seeing some stuff above there. So for this one, I'm just kind of curious from the group, if anybody recognizes anything with how this bowel is looking in a kid who has a history of constipation. And, you know, for the purpose of entertainment, let's say that this is like distal ileum.
Sort of like fecalization after like kind of long-term slower transit or obstruction.
Yeah. So, I mean, again, we get plenty of kids who come in with history of constipation. And I know there's something out there where you're supposed to like, you know, measure the diameter of sigmoid colon versus more proximal colon. You know, sometimes you can just feel balls of stool and then, you know, who really cares about ultrasound? But I feel like, you know, there's some where, you know, doing the scan, I'm like, I'm not really impressed with what I'm seeing in the colon. And then you get to the small bowel and you see this, and it's like, oh yeah, this has been going on for a while, huh? So again, just another like interesting thing to pick up on your bowel imaging. There was an oh by the way with this kid though, and his oh by the way was that he also has sickle cell and has a prior history of splenic sequestration. So, you know, with his belly pain, mom, you know, isn't quite sure what she thinks the left upper quadrant feels like, but since he has a history of, we're going to go take a look. So there's our spleen, and you see the kidney coming in and out of here. So do we think from this splenomegaly or no splenomegaly? And maybe I should also ask who uses the ultrasound instead of your hands to determine whether or not your patient has splenomegaly.
I've measured historically. There's a paper, I think last year that JIUM put out that had kids measurements, normal spleen, normal liver, normal kidney, that I printed out and keep in our office.
Yeah, so I'm very like averse to measuring. I'm not sure if that's because I'm lazy or don't like math or like the Gestalt, because like Gestalt is such a great word and I love being able to say it, like, oh yeah, just clinical Gestalt. Sonographic Gestalt. So the Gestalt, and you know, I've talked about this with our peds radiologists in the past, you know, you have all the measurements, but really it's like, if the spleen doesn't go down below the lower pole of the kidney, you don't have splenomegaly, regardless of what your measurements are. Because the spleen's like such a weird shaped organ, like I can only imagine, you know, majorly screwing up the measurements if I tried to measure that thing. So anyway, in this case, like all his labs are normal. We didn't feel like there was splenomegaly here. I gave him enema for his chronic constipation, felt great, ended up going home. Now, the other interesting thing with him is that he had a series of visits to RED. So in the top left corner was his 1 week prior. And so there's his spleen, there's his kidney. And the week prior, I had seen him also. And, you know, he looked like sonographically had splenomegaly, and actually on exam, you could feel his spleen tip down, but his labs were fine. He was feeling fine and spoke to hemonc, and they were gonna follow him up, and mom was cool with it. So went home with this little bit of splenomegaly. He came back for this images that we had, that I just showed you. And then a week afterwards, he represented again. And for some reason, he kept on coming back to me. So I got to scan him one more time. And then here, it's from a slightly different view. This is more like a prone view, so they had him roll over a little bit. So the kidney is closer to the probe than the other ones, which is more like your fast view. But you can see the spleen coming down well below the lower pole of the kidney. And at least on the visit a week later, his hemoglobin dropped 4 grams. So, you know, that time he got admitted. So this one happened to be like, had a body habitus that was very amenable to actually doing an exam, but not all the kids are like that. And so I am just genuinely curious from the group out here, how many people like trust their physical exam findings, or, you know, I know we're not supposed to say it, but use the ultrasound as the physical exam.
Me personally, I rarely use the ultrasound to sort of look for that, but splenomegaly. But it's interesting, like you said, that if it's below the lower pole, I just generally go by clinical exam, and I usually also ask the parent. Usually, if they know like where the spleen usually is. But for me, it's just more likely a clinical exam.
I have used it to confirm that what I was feeling was the spleen. Like I found an enlarged spleen on a 1-year-old with fever. So I was just really surprised and I was like, oh no, like what is this? So I used ultrasound. It's like, okay, is there spleen? But I haven't used it on like your obese teenagers, you know, that you wouldn't be able to feel their spleen. So I don't know, that'd be interesting.
And Adam, I feel like I do it a fair bit, particularly like younger kids who are just not going to fuss, or there's truly belly tenderness and I'm not going to trust because I got to tense up. I find I'm routinely asked in passing to do it because we have a pretty large sickle cell population. And I use the same gestalt. I don't bother measuring.
Yeah, and I feel like our parents, I mean, I know they get trained to do it, but when I ask them, you know, how their kid's belly feels compared to other times, I get that look like I just asked them about a homework assignment that they didn't complete. So yeah, I tend to use ultrasound a lot. But as my fellows know, that's kind of my answer with everything. So, all right, moving on. So we have a 19-day-old with non-bilious, non-bloody vomiting, 1 whole day. No fevers, no blood and stool, no blood in the vomit. We try feeding the ED and they throw up. So, you know, this isn't trying to mystify anybody. Please ignore the misspelling. Everything else about the fellow scan was great, except for the spelling of pylorus. And so, you know, one more thing where, you know, I think you've probably heard me say that you don't need to really measure pyloric stenosis. You just look at it and it's positive, right? When it's negative, it looks negative. When it's positive, it looks positive. End of story. So it didn't quite go end of story. So of course they went to radiology. Radiology got that nice image up top. And then for whatever reason, they got that short axis image below and then measured something at 0.28. And so they called it normal. So I didn't know about this case until like the week after. So when we were doing the QA, you know, I was like, oh, great pickup. And then saw all these other images. It's like, what happened? So what happened was, you know, he was still vomiting, so he couldn't be discharged. So he got admitted. He got re-ultrasounded. Again, for whatever reason, they keep on doing the muscle width measurement in transverse instead of in long axis. You could actually go back and like calculate the distance of like, what's the, where's my mouse here? I can't get my mouse back. Like the interior part and recognize like, that's not the pylorus. They're, you know, measuring the part that's just prior to the pylorus starting. They're getting like the rest of the regular gastric wall. He got an upper GI, and with the upper GI, they said, well, it's not pyloric stenosis because there was still contrast that made it through the pylorus. So they were calling it pylorus spasm. And then our peds radiologist came back from wherever he went to and actually did like the right measurements again and, you know, went to the OR as he should have been. And I hate to say it was also not the first time that it's happened where, you know, we've had something like this in radiology has called something normal when it obviously wasn't. I was just talking to someone the other day, and the last time that I had this case, I remember telling the family, like, listen, this is what it is. Nothing bad's going to happen over the weekend. They're going to vomit, but really there's still going to be some absorption. They're going to stay hydrated enough. Just come back on Monday, we'll repeat it, and then you'll have the surgery that you need. Which is kind of a pain in the ass. But this kind of gets to the topic of, you know, what do we kind of expect with pylorus spasm versus pyloric stenosis. And, you know, at our shop, we've got a peds radiologist, but it's sometimes one of the other general radiologists that are covering. And they will interpret anything that goes through the channel as not being pyloric stenosis. And I apologize, even now this thing looks a little bit darker than it did when I first looked at it. but this is a case where it's really just a little bit of pyloric spasm. The walls are a little bit close together, but it's still like an obviously normal study. You can see the channel, it's dynamic, it's curved, it's opening up a little bit, it's relaxing some. So, the dynamic nature of the channel is sometimes just as important as everything else. And you could have pyloric stenosis, and there is still, microscopic space between all the gastric rugae through that channel, and fluid gets through. And that's just like a normal thing, and not to like freak out about it or give it too much credence. And so I don't know if anybody's ever had any similar experiences at your own shops with this, of the borderline pyloric case, or how it gets managed, or even whether your surgeons would only accept a 4 millimeter as opposed to 3 millimeter, because that's certainly in the literature also.
So I've had cases where that it is that borderline, and the kid is on the younger end of the spectrum. So that in a week or so, it's probably going to be greater. Like I had a 3-week-old with a 3 millimeter measurement, and I was like, "You're 3 weeks old. Like, what's wrong with you?" And ended up getting an upper GI, and they were like, "Yeah, this is positive," and then went to the OR. So.
All right, keep moving on.
Hey, I also have an interesting pylorus case to share that Antonia Riera just reminded me of. But we had a patient who came in with symptoms that were really concerning for pyloric stenosis, went to radiology, and it was believed to be negative for pyloric stenosis, and then but admitted for monitoring and hydration just because of the presentation. And in the morning, they received another pyloric stenosis ultrasound because of the continued symptoms, and found to have very clear pyloric stenosis. And it was turned out that on the initial imaging, instead of measuring the pylorus, they were measuring the esophageal gastric esophageal junction. So that was a false negative scan initially.
And that was from radiology that they measured the esophagus.
Exactly. It was sorry, Antonio, do you want to?
Yeah, it was there was felt to be passage of fluid through the pylorus, but really what was being caught was which I don't even know how to do, was the junction of the distal esophagus meeting the stomach. So that retrograde flow was felt to be at the level of the pylorus, but
so if that false negative can occur with a radiologist, it can certainly be something that we fall into as well. Sure. So something to be.
So wait, I want to put my fellow on the spot here, because Adib, I saw your face pop up, so I know you're on. Do you want to tell people how to find the esophagus? Are you still there?
I'm right here. Yeah. So which I normally, a lot of the times, always troubleshoot is if I find a structure which I think is the pylorus, then when I see a vessel, which is the aorta right below, then I know that that's not the pylorus, and I'm looking at the esophagus, if I'm not mistaken. Please correct me if I'm wrong.
No. So, it's not, I don't think it's all that hard to find the esophagus. You're a little bit higher, and maybe your probe is angled a little bit more cephalad than caudad. But that last little GE junction, it doesn't come like straight down to the stomach. It does like a little jog where, if you're in a transverse plane, it looks like it's in that long axis. And I'll be honest, I've been at a national ultrasound talk and seen somebody present the pylorus, and it was a beautiful picture of the esophagus. And when you have reflux, which, all these kids have, because A, they're infants, and B, 90% of them are negative, but because they're coming to you for their vomiting, they're either overfed or, they've got something that's going up in the esophagus. You're going to see things go from your visual right to your visual left, which, makes you want to think that that is the pylorus. So yeah, with my fellows, when we do the pyloric scans, a lot of times we look at the SMA and SMV, but then we'll also make comment about the esophagus, so they kind of know the difference between the two, because very often they'll look very much alike.
Personally, like I've always found like whenever I try angling towards the head a bit more, then I end up finding the esophagus, like, you know, so.
Yeah. Well, that's where it's supposed to be,
Yeah.
up top. All right, moving on. 3-year-old, 5 days belly pain, seen in an outside hospital, and supposedly had a normal abdominal x-ray a couple days prior, but was having crampy abdominal pain, some mild periumbilical tenderness, apparently no vomiting, no fevers, no blood in the stool. A common thing, common presentation today. And so here's an ultrasound, and we're somewhat in the neighborhood of the right lower quadrant. You can see the iliac and the psoas on the left-hand side. So anybody want to make any comments about what they're seeing? Got some fluid-filled loops on the left-hand side. That's okay, you can just keep the mental image of this. There is another oh by the way to this case, and the oh by the way is that he was actually found to have intussusception, and he had been reduced with the barium enema before I walked down to the ED. So this scan was actually 2 hours after he had been reduced. And he was kind of crankly and rolling around, and the dad was a little bit unhappy, but we were still able to get the scan. And I kind of wanted to present this today because Erica had shown her images of that case where she was unclear, like, you know, post-reduction, did somebody re-intercept or not? And, you know, thinking about her case and those images that she presented, I think that kid probably did re-intercept and then, you know, spontaneously reduced on their own. But the only thing I can add is that, you know, sometimes when you're looking at these post-reduction kids, this one segment of the TI where you're, you know, getting a great look at the ileocecal valve, which is that lip-like structure thing we're seeing project into the fluid-filled lumen of the cecum. You know, if you didn't know any better, you'd say, well, that kind of looks like a very sandwich-shaped looking structure. And if I rotated on that into, you know, the 90-degree plane, that would become a very targetoid looking thing. And I don't have the calipers on here, but, you know, it's probably going to come out somewhere around 2 centimeters. You know, it's kind of worth taking a look at the IC valve when you can see it, because it is viewable. I don't think it's totally noticeable on like every single abdominal sono, but certainly on kids who've got like a nice watery diarrhea, you know, this is a time to go looking in that cecal area and see if you can start recognizing it, and then, you know, just making it like a familiar face when you're doing these scans. I think I made the comment before, like it should probably be within our wheelhouse to, you know, be used to at identifying interception. That's the easy part. But then, you know, if the kids have some colicky stuff afterwards, to know what that post-reduction picture looks like. And at least when you're doing it with a liquid barium enema, you'll have, you know, very fluid-filled bowel. If you're doing it with an air contrast enema, you'd probably have a really hard time imaging anything. But anyway.
Adam, it's Erica. That's a beautiful, beautiful scan. I love it. Did he get any like comprehensive imaging as well, in addition to what you did, or was it like not really indicated?
No, I mean, you know, they always get imaging after what we do.
Yeah.
So he had like a totally normal interception and had a reduction with good reflexive contrast into the small bowel.
Yeah.
And is it your practice at your shop, they do barium enemas and not air enemas?
Yeah. For everything.
Okay, because for us it's air enemas, so I think we'd probably have a hard time seeing this picture. It's beautiful though.
And also always begs the question, I mean, I'll talk about one of the things that's on my bucket list for the ED this year. But when you think about like what they do for the barium enema with fluoro, you know, there's no reason why it can't get done with ultrasound. And there was a paper that came out someplace out east where they had looked at like 200 ultrasound guided reductions of interception, and, you know, there was no like worse outcome doing it that way than any other way. And there's really like nothing technical about reduction, you're literally like just hanging a bag of fluid at a certain height. And, that height creates the pressure wave. And, if you're not having it reduce, you raise the height a little bit higher to get more pressure. So to me, that seems like an ED procedure, but I may be a couple of years ahead of my time. All right, moving on.
Let me know what the RCT looks like when it comes out.
All right, 19-year-old, because we're seeing lots of older kids in our PZD these days. 19-year-old, 3 days, worsening abdominal pain, some vaginal bleeding going on 3 days, LMP a month ago. Also no vomiting, no fever, no blood and stool with, surprisingly normal vital signs, and just happens to be positively pregnant. And so maybe this one doesn't have quite as much of diagnostic equipoise here. So we have somebody with belly pain who's positive with pregnancy and has that on her transverse view of the abdomen. Doesn't look any better sagittally. I know we don't have a good focused view of the uterus. There is a little bit of fluid in that endometrial space, but it is not a gestational sac and it contains no yolk sac because that happens to be sitting outside of her uterus at this time. And the docs that day did a good job, went up to the right upper quadrant. And so we've got a positive right upper quadrant. So, again, with what Erica's asked, what do we do with a positive study? So, positive pregnancy, fluid in the right upper quadrant, this is a ruptured ectopic. There's no two ways about it. And we still need to get an official study, but I was actually a little bit proud of the time course here because, they got the study, they called OB right away, let them know what they saw. OB was at bedside within 45 minutes of this patient hitting triage. They got ultrasounds within 30 minutes of that. And then the interesting thing was that the patient never came back from ultrasound. And, the doc that was on was like, what happened to this patient? Because, ultrasound is like a football field away from us. And we need transport to bring the patients up and back. And we were like, what happened to the ruptured ectopic that hasn't come back? She could be crashing. And she wasn't crashing because she was already like up in the OR waiting to get operated on. They just couldn't put in any orders because we didn't put in a mid order because we didn't know where she was. So the biggest delay was her sitting up in the OR area waiting for us to put in the admission. And was also in and out of the OR enough that, the ruptured ectopic with that much fluid came into us at the 2 o'clock hour and left by the 7 to 8 o'clock hour, which is incredible, but apparently is a thing. And she hasn't come back, so that's even better. So yes, even though we still have to send patients to radiology, what the thing I like to say is that we're cognitively unloading the patients, we're making the consult calls and getting closer to whatever their goal-directed therapy or surgery is, hopefully, minimizing this clock time. All right.
Hey, Adam, for follow up on that one, can you guys get rads to come to you? We've had like now in the aftermath of several different M&Ms that, involved delay of studies and whatnot, and sort of balancing like sick kid who needs access and fluids and antibiotics, but like trying to get imaging for definitive. And especially now with COVID and sort of exposure risk, we've sort of been forcing our RADS folks, forcing is probably the wrong term, but collectively agreed to do more in-room studies so that, you don't send them off to the suite to die if they have the bad thing.
So I kind of joke about them being a football field away. They are a distance away, but that distance, it's like the main ED between us and radiology. So, if anything happened, the main ED is right there. So they're really not like too far away from people who could handle a code. I've never asked for radiology to come to us for this kinds of things. They have people that do portable ultrasounds, and they're generally like wheeling them up and down from the floors. I think if there's somebody who was really like in shock, then that would be like a hard conversation with the OB attending, and would be for them to come down to the bedside and take a look at what we're seeing, and say that they think that this patient needs to go somewhere else other than the OR in that clinical case. I think with normal vitals, we can buy ourselves a little bit of time. Abnormal, the funny thing is, as much GYN pathology as we see and ectopics that we see, the overwhelming majority of them don't look any different than any other patient waiting for anything else. They're just sitting there chilling on their phone. And even when they're tachycardic, they're still not like, all of that shocky for whatever reason. So no, we don't. It would be great if we could. I'll have to add that to my wish list.
Well, do you think if the patient was unstable that the outcome would be different? Like would OB request a comprehensive scan at your shop?
I think if they were
unstable.
If they were unstable, I would have a much better chance of having them get directly to the OR.
Yeah. That's pretty predictive. The fluid in the right upper quadrant in ectopic in particular is pretty predictive of operative intervention, right? So I think anybody who's stable would get a comprehensive. Do they find anything different in the comprehensive? Do they find the gestational sac, or could they better qualify anything other than lots of messiness in the pelvis?
Right. I mean, I guess in theory, you could have like a ruptured ovarian cyst with a concurrent pregnancy that could give you that much fluid. I mean, we've had plenty of hemorrhagic cysts that have given fluid up in the right upper quadrant and even required transfusion. So again, I didn't show the image of a closer up view of the uterus, but there wasn't anything there other than just some fluid, but certainly no yolk sac or anything else.
I mean, to Erica's point, I feel like this has been pretty well delineated in the adult ED world, and I don't know why it would be any different for your 18-year-old or 19-year-old. I mean, in terms of like straight to the OR with unstable vitals, positive fluid in the right upper quadrant. I mean.
Yeah, I think it's like the adult lit's like a positive likelihood ratio. I think it's 118 with positive pregnancy test and fluid in the right upper quadrant. Kate and I were chatting. We had one in the fall, which I think I presented in September, that had a radiology study before I came on shift that was read as like torsion versus like perfed appy, because she had like an elevated white count, and it was the classic like didn't have her pee because she swore she didn't have sex, and so they're doing the transabdominals to get the views. And then as I came on shift, her serum comes back positive. OB's in the room talking to the family about like, oh, options of like delayed OR, maybe it's this, maybe it's that. And I looked at her and she had just fluid everywhere, and you could just watch her heart rate was still technically normal, but she'd gone from like 70 to 90 and was very tender. And then we had a repeat hemoglobin, came back and it dropped like 4 points. And I showed the OB resident, I'm like, please take her out of my ED now. And they went right up to the OR, and she ended up going hypotensive and seizing on induction. And they took like a liter of blood out of her belly and gave her a couple of units in the OR. But so yeah, that was a fun one.
Yeah, again, knock on wood, most of ours are stable, have been stable so far.
Can someone remind me, why do ectopics bleed like this? What is the pathology for all this bleeding?
The rupturing.
That, like, I guess the fallopian artery, like what is rupturing that's bleeding so bad?
Yeah, I don't know if there's any specific artery because of all the different like locations that it can be, but obviously like it's a very vascularly active growing structure that eventually is going to outgrow its ability to continue to grow and eventually overgrow its space. I don't know. That's a good like in theory question. We never get pictures from the OR of like what's the source of this thing.
example, like when they go to the OR, yeah, it ends like, what are they doing? Like they take out the thing, but then they must cauterize something because, you know, like how your patient got discharged. I'm like, I guess they fixed whatever it was. And I was like, what did they fix exactly besides take out the ectopic?
Yeah, I mean, in this case, I think they did like, you know, they took out the tubes. She's missing parts on one side now. And I can't find my mouth, but I saw that there's like 17 things, which I'm assuming are in the chat box. So if they're like important for discussion, someone can shout them out, because otherwise I can't access them at all.
We've been discussing them.
Stuff here, that's fine too. All right, I got definitely more cases than time for this talk. So I guess this one is interesting enough. And actually, this is the one that I wanted to talk about, because this is on my bucket list. Adib, listen up. All right, so this was a dude who came in with left-sided scroll pain. We start off with our buddy view, transverse. At right side, you know, looking kind of homogeneous, normalish looking size. The left side has the early appearance of something not being right. So looking a little bit more on the left side, more hyperechoic. It's got some fluid around there, and it's got something else sitting in there too. So we start off looking at the normal side, getting Doppler. So we have intact arterial flow, yay. And then coming on to the left side, I don't think I have the clip. You'll have to take my word. We made several attempts for flow and found none. But looking at that extra thing that was inside, saw this sitting up at the top. And so when they talk about torsion, you know, there's, yes, the lack of blood flow. And then there's supposed to be this whirlpool sign that you can see torsion in the cord with everything spinning around, and then you get vascular flow of that area. In this case, we didn't have any vascular flow at that specific point, but that is like clearly the pedicle of the cord swirled up in a very clockwise rotation. So this is on my bucket list to start detorsing these kids in the ED. Because with something as time sensitive as this, and you know, we can you can see what direction it's twisted in. So this would be like a very easy thing to image as you're untwisting. And you know, I'll bet I could even, if we went back through here, you could maybe even calculate how many degrees of twist there is in this structure. You know, it's at least like a 360 that's around there. And I'm just curious if anybody else has had conversation with their urologists about doing manual detorsion in the ED.
I've asked a couple times and they always sound very shocked and tend to discourage the idea.
Yeah, Adam, we actually
in the OR,
yeah.
They still tack it down.
I've been willing to try a couple times, but I'm not gonna, you know, if they're saying don't do it, I've been reluctant to.
I never understand why they would say don't do it. That makes no sense at all, because they're not at the bedside. It's always 3 a.m. and I'm standing there and I'm like, no, I'm gonna do it. So I don't even ask permission. And so in our ED, there's this like pathway that, you know, they're working on door to OR time and blah, blah, blah. So from triage, they call the main PEMDoc to come out to triage and look at the testicle. And then they do like a twist score and activate urology and this, that simultaneously with ultrasound. And so I've had, I don't know if I mentioned in this forum or where, but definitely, you know, classic torsion, no flow on my ultrasound, and I detorse him. And then he goes to upstairs and they're like, oh yeah, hyperemia after, makes sense, etc. And that kid actually, urology was like, well, we can do outpatient orthopexy. And so the kid actually went home for like next week orthopexy. So it's like, I don't understand why we don't do it more and why he needs to go to the OR for detorsion. Yes, he needs orthopexy. Yes, but tonight, I don't know.
I'm curious, Dr. Rosemary, after you manually detorsed him, did you get did you do like a repeat bedside and
Yeah.
detours?
Yep. Because you know, so the whole open book thing, totally, like most, like 85%, I think open book will undo it. And I didn't bother with like fentanyl, blah blah blah. I was like, he needs it detours, like it doesn't need fentanyl. And so one little yelp, and then he was like, no, I don't feel better. I put the probe on. I was like, yeah, he doesn't have color. Another twist, and then you really got to hold on and like give it a yank. It doesn't want to go. And then put the color on. And then you put the color on, and there's color. And he's like, oh, I feel better. I'm like, yeah, you do. So it's really great. And it's like nursemaids, but like way more private.
That's awesome, Rosemary. I'm sure all the guys are like, oh. But Adam, can you show me that image again and tell me, so you, like Rosemary alluded to opening the book. And I think some of our urologists are worried that it's going to be the 15% where you're twisted actually in the wrong way. So my question is, how do you look at this image and know that you can just open the book and know that you're going to detorse it properly?
I don't think you can look at that image and say which direction this is going to go in, but given 85% is pretty good odds, you know? So if it doesn't go well, I mean, urology is still coming in, but I certainly, you know, I think there's resistance to turning in the undoing direction, you know, like I imagine that if I wanted to twist it more, I could probably do that easier, but I certainly, I mean, yeah.
And I guess,
I mean, it's kind of, my thought on this is that, and I would say it to urology, it's the testicle has no flow, correct? I think we're all in agreement. That's the primary problem. So if I twisted it the wrong way, it still doesn't have any flow, correct? Like, what have we changed? Nothing. So really, you can only make it better. You can't make a dead testicle more dead. And if you don't get flow back, you know, they're still going to go to the OR. Maybe, you know, urology is still on board. The endpoint in this is they feel better, or we do a bedside and have flow and probably, you know, repeat some radiology study. And, you know, all of that could probably get done in the amount of time that it's going to take them to get from wherever they are to wherever they need to be. Like, I imagine your detorsing procedure probably took 5 minutes or less.
Exactly.
I think this is one of like these cool things that just, you know, until it's done normally, or when it starts getting done normally by us, we'll look back and be like, why did we ever wait 2 hours for somebody else to do it?
Exactly.
And
Rosemary, we at Cohen's, I kind of, I do it the same way you do it. I actually have the ultrasound tech right next to me, and so long as they document no flow, I detorse, and then on the same account, they take another shot. So I do it exactly the same way as you. I'm a little bit, I do give a little fentanyl just because I feel a little bad, but that's okay. That's
I was very excited. I was a little hyper excitable. I know. I was like, let's do this. Let's do this before they scoop them upstairs. I don't want him to go. I'm not waiting for them to do this, that. I was like, we're doing this now. So I mostly did want to.
We also don't give birth, so you know that's the counter.
Right. But to answer Erica's question, you know, if I usually detorse about 180 degrees at a time, especially the early ones, like the kid comes in with an hour of pain. It's not going to be 720. It's going to be 360, or maybe if at most 540. So I detorse open book 180 at a time, and then you'll feel it. You know, you can actually feel the spermatic cord in the back that's extremely tight. And I'll guarantee you, if you're doing it the wrong way, he's going to be even more pain. And it's that And once you get to even that, there's that point where you can actually detorse and it actually snaps right back. And all of a sudden the kid's like, oh, thank you. You're like, but it's one of those things that I only do incremental detorsion. And just for, whether it be for because of the way it torses, Erica, I know that the numbers are there, but the most common thing is going to be medial torsion as opposed to a lot or external torsion. So you try. I don't think I've ever thought either way, and I agree with you. The images only tell you no flow and snail sign or roll sign, and then you're off to the races. And I agree with Rosemary 100%. There's no reason why we can't. And our urologists actually have done exactly the same thing. Depending on COVID and all that stuff, 99% of the time they'll just send them home and set them up as an outpatient, which is a win for the patient. So this way they're not, but you do have to tell them it could happen again.
I also think this is one of those places where we're largely all at academic centers that have the resources for urologists to be available pretty quickly. And so it's, one of those skill sets, particularly for like trainees where, not everyone we're training is going to be at that same sort of site. So like one of my fellow colleagues was EM trained out of somewhere in Louisiana, and I'm still not quite sure. And they had very minimal specialist availability. So he would attempt these very aggressively, and he would try to open twice and then close once if it didn't work. The place he got stuck is he was notorious about not saving his images. So then it became hard to sort of prove what he had done well. And so if well documented, seeing it, testing, re-ultrasounding, testing again, I don't see any harm. I will say I have not done it, but it makes a lot of sense.
Yeah,
Can
that's
you review?
a situation I've done in before too, Matt, was at a community hospital where it was a 16-year-old who was approaching his 8-hour mark and had no flow, and the adult urologist was refusing to take him to the OR. So it was also a facility where we didn't have ultrasound. So I just manually detorsed him and sent him into town. And luckily he had a salvageable testicle at that point.
Can someone review for me the whirlpool sign that you're talking about? Because actually I hadn't heard of that before today. Is it just looking at the twisted spermatic cord at the superior portion of the testicle?
Yeah, I think this image is just that. I'm trying to save it. But the swirl here, like here's the inner to outer on the swirl, and you can see it rotating around. I think how they describe it with the cord, though, there's like, it still has some intact flow. So it's almost like with a volvulus where you can see the vascularity twisting around. And on this one, we just weren't able to get the vascularity on it. If it was there, we could see some on like the outer portion of the twist, but not the inner.
Because I think our radiologists, they look at the cord actually in longitudinal. So there's this like mandatory longitudinal view that they like to get that I find very difficult to interpret when I look at the comprehensive scans. I haven't seen this. They don't routinely get this view on our scans here.
Yeah, I think this is just, this is what they're looking for in the cord. This is just like in the scrotum instead of in the cord.
Yeah, it's very cool.
So I know it's late and everybody's got to go off to their other things. I do want to give one plug though, because I talked with Mark Tesaro, who did publish a case series from sick kids on their scrotal ultrasound and their relative accuracies and whatnot. And it's, one of many things that it is in our interest to produce larger data sets showing that we can do what we do. So for the people that are potentially interested in doing this on a larger scale, let's get to start combining data. And that's how I'll end it.
Thanks, Adam. Those were great cases, especially the last case. Great discussion. I had a case that I think back in the, thinking retrospectively, I probably should have tried. So after this talk, I'm probably gonna, if I'm in an overnight again, and then there's a delay, I'm gonna try to detorse it.
Well, thanks everybody.
Yeah, thanks everyone. And Matt, send for those CCMC. So actually, they're having another lecture starting right about now. They're just gonna go over GYN. So the link is in your comments if you guys want to join that as well.
Yeah, Henry, I just posted the link for the lecture.
Okay, great.
Good to hear everyone's voice.
All right.
Have a good day, guys.
Take care, guys.
Bye.